the new payment model is it provides for a lot of opportunities for our healthcare experts. I think it expands the ability to use other folks as part of the care team, and so knowing that caregivers can receive supports, that they also can receive possibly payment for their services, as well as other practitioners being added uh, as having the ability to provide services, I think are all really important. I think also too, CMS's commitment to emphasizing the importance of social determinants of health is an important addition, with adding the assessments that one can take and then being reimbursed for. And so excited to see a lot of these changes. It does make me think, and one of the things that I would caution or at least recommend is that uh, with um, with these with these changes, that we look at the model as well. And so there may be some changes to what the margin will be and how we'll implement programs. Because I know that, there's a limited pool of money, if you will. And so where we've incented in the past and how we've incented and paid could end up being potentially different. And I would think that that would be something that we would at least want to be aware of and have sight to, because as we're reimbursing our caregivers, reimbursing other members of the care team, I know that there were expanded capabilities around behavioral health. And in order to furnish and support those programs, we may see more changes like we saw with V28. I'm not saying, and I know that when that came out, a lot of the industry was concerned because of the supposed depreciation in revenue reimbursement. And what I would recommend is that you not think of it that way, but rather other places where you can ameliorate any depreciation that you might experience. In actuality, right, it just makes the system better. And so it provides more opportunities for people to be reimbursed and provide better care for the patients. And so one of the things that I would recommend doing is starting to look at how you're managing your total cost of care, and that you have the right supports in place to fully support these populations, that it won't be enough, right, just to do SDOH assessments and get reimbursed, or caregivers get reimbursed. It's a step in the right direction. But like most things, and like we've seen with our other programs, it's just the start. And so making sure that you're providing those full rounded supports and implementing strategies throughout the continuum. I think one of the ways to do that is going to be, again, an emphasis on data and technology, and making sure that you have tools that are at all aspects, so all junctures of where you would interact with the patient, the physician, right, where data would be important. So at the point of care, for the data analytics team, for those that are designing your programs to determine if they're successful. So there's all those different junctures or intersections where we would want to make sure that we have data available where there's key decision points. They're paying caregivers. Also, too, though, there were a bunch of things that came out last week. So one is the paying of caregivers. They also added in and further clarified on the SDOH assessment and being reimbursed for that. And then I know that they've added other specialties to be added to the physician fee schedule. And so around behavioral health, there are additional therapists or other clinicians in the behavioral field that have the ability to be reimbursed, but also to capture risk adjustment. And so when we look at the provider schedule of who are accepted or appreciated types to be able to capture risk. There's been some additional clinical levels, if you will, or other clinicians that have been added to that model. And again, in support of behavioral health. And definitely, I think, a nod to the importance of behavioral health to one's overall well-being, as well as just, the lack of clinicians that we have in behavioral health. And so that recognition that even though we know that that's important, unfortunately, there aren't enough behavioral health advocates out there that can work with patients in the ways that we need them to. I would say that while I think that it just like anything with any change, and I don't mean to sound I'm usually very optimistic, and I am. I think that this is all done for the improvement of health, and we'll have better outcomes. But I just want to I think there's a cautionary tale here to our audience and to our industry, is that really look at the whole extent of what's being published and adopted and put out there, because it's not enough to focus on a couple of components. I think what you'll find is that if you're not fully circumspect about the rules of these programs, that you could find yourself not as successful maybe as you're expecting. And so one of the things, right, was around beneficiary alignment and being able to attribute beneficiaries to you. And I think that that longer period definitely helps. So it maybe slows down the, and a lot of it, I think, has to do with the data, not getting the data in a timely way to really know who your patients are. And so you have patients coming on and off the rosters before you even have a chance to, take a breath. This may allow patients to be on rosters longer, right? Because it's looking at that 24-month period versus 12. But I think what the difference is that now what you have to recognize is you have the opportunity to potentially still not get the risk or capture the burden of illness of those patients within that time frame, and that you still have the opportunity to have catastrophic events. And so they're with you longer. And so the period is longer in which those events could happen. And so one of the things that I would want to make sure that I was paying attention to is not just who's on my roster, but who's on my roster, right? So looking at the data around those patients so that you can better manage them. Because I don't think that, while 2 months may adhere them to you longer, it doesn't necessarily preclude you or protect you from any of those catastrophic events that could potentially arise. And you're still going to want to do the good work that's necessary around managing those patients, around because now they have a longer period, right, in which to exacerbate. And if you're not seeing those patients, if you're not capturing their risk, you end up, I think, in a similar position. And so just knowing that the programs are requiring, and this is speaking holistically, right, not just to ACO REACH, but even Medicare Advantage, Medicare, holistically, the programs are becoming more complex. There's more components, which I think is an important change or an important direction and focus, because it says that, healthcare is complex, and there's a lot of components that go into how one is healthy. And if we're not attending to all those components, right, we run the risk of not being successful. But I think the other piece to that then is that we have to be more tactical. We have to be more strategic in what we're doing, because we could very quickly start to erode margins. And just to give you an example, thinking back to ACO REACH, when folks got into ACO REACH, a lot of them chose global risk, and they automatically chose, taking global risk, right, on all those patients. And what I think they didn't count on is that while they were expecting to be able to see those patients, to be able to capture the burden of illness and be able to report it. It was challenging. They didn't know, right, who their patients were a lot of the time. And so it was difficult to capture that. And then they had catastrophic events. And so taking that global risk was challenging, right? Because not all the components were in place. And I think we'll continue to see more and more of that. One thing I'll say too, just working at an at-risk physician group for many years, and this was many years ago. One of the things that we would notice, we had about 100,000 Medicare Advantage lives, and we would see about a 10,000 month over month attrition rate. And we looked to see, right, did they go to a different plan? Was there, somewhere else they were going? And they just left the plan. The thing is we were getting about that same number a month too. And so we had about 10,000, that fluidity or that fluctuation month over month within that plan. And those patients left us. They didn't, normally you would look to see, oh, are they deceased? No. Did they change health plan, but they're still within your group? No. They might have moved away. They might have chosen a different physician, not within your network. There were all sorts of reasons. And then, like I said, we were getting about 8 to 10,000 being added to the roster month over month. And so, those types of things are typical movements within healthcare. And agree, these programs are intended to make patients, if you will, stickier and to have a good experience with you and to stay with you. But it's not going to be, the only thing. And then the other thing I would say from my experience in the same group where we had that 10,000 on and off month over month, one of the other things that we recognized is that patients that were new to us, and this was Medicare Advantage, so patients that would come new to us in January 1st, typically, and we were trying to determine based on risk score, if we could anticipate who were those patients that would end up in the hospital. And what we found is that usually within 2 months' time, those were the patients that had come brand new to us. We didn't even have a risk score on them yet that had some catastrophic event. And so, just knowing again that you have those 2 years, I wouldn't rest on my laurels, right? Thinking that, oh, I have 2 years. You're still going to have to be as active to manage those patients because those events happen. And especially, I think a lot of times, like I shared, we had brand new patients coming to us, and within 2 months' time, there was a catastrophic event, and there was really no way to tell. Someone could say, well, look at the high RAF score. Well, you didn't have a RAF score because they were brand new to you. But low RAF score wouldn't necessarily mean anything either because they weren't getting in to see the patient. And then their first event that they had was this catastrophic illness, right, where they were admitted to the hospital. So those would just be things that I would be wary of and cognizant of, and not to assume that, because you have additional time or because we've added these extra components, we need to do something with them. They weren't just added without a lot of thought, obviously, right? But we need to really think about how they add to and also transform the current programs that we're in. And again, not assuming all the positive, but also being a realist, I think, and recognizing that there are other things that we need to do in order to make sure that you continue, in your practice to be successful.